Hello, everyone, and welcome to today's session. We are taking a deep dive into a condition that affects millions of lives, but often remains hidden behind closed doors. We're talking about ulcerative colitis, or UC.
And specifically, we are looking at the evolution of how we treat it. If you've been in medicine for more than a decade, you know that the goal of UC treatment has fundamentally shifted. It's no longer just about making the patient feel okay. We are now aiming for deep biological healing.
Our lesson today, determining ideal targets for treatment, is really a roadmap for this new era. We're going to cover everything from the basic pathophysiology to the systemic manifestations that most people don't associate with the gut.
We'll also spend a lot of time on the treat-to-target strategy. This is a concept borrowed from rheumatology and cardiology, where we set a biological goal, like a specific blood pressure or a specific joint score, and we don't stop adjusting therapy until we hit it.
But before we get to the high-tech targets, let's define the enemy. Mark, in the simplest terms, what makes UC different from other inflammatory bowel diseases?
It's all about the location and the depth. UC is strictly limited to the colon, the large intestine, and unlike Crohn's disease, which can tunnel through the entire wall of the gut, UC is a mucosal disease. It stays on the surface, but it is relentless. It starts in the rectum and moves proximally, causing continuous, uninterrupted inflammation.
It's that uninterrupted part that makes the diagnosis so distinct. Let's get into the why behind this disease.
One of the most common questions patients ask is, why me? Why did I get this? And the truth is, the answer is a complex puzzle of genetics and environment.
The lesson notes that UC is more common in developed countries, particularly in North America and Northern Europe, but we are seeing a massive surge in newly industrialized nations. This brings up the hygiene hypothesis.
Right. The idea that our environments have become too clean. Without early exposure to various microbes, our immune systems become bored or hyperreactive and eventually start attacking our own commensal bacteria in the gut.
And then there are the paradoxes. Mark, let's talk about smoking. This is always the most confusing part for students.
It's wild. While smoking is a major risk factor for Crohn's disease, it actually appears to be protective against ulcerative colitis. We often see patients who develop their first flare of UC right after they quit smoking.
Now, we're obviously not telling people to smoke, but it tells us something about the nicotine or the carbon monoxide having an immunosuppressive effect on the colonic mucosa.
Another interesting risk factor is the appendectomy. If you had your appendix removed for true appendicitis before the age of 20, your risk of developing UC later in life is significantly lower.
We also have to look at breastfeeding. There's a strong correlation showing that breastfeeding for at least 6 months can be protective. It all goes back to that early priming of the immune system.
Let's talk about the clinical picture. A patient walks in. What are the hallmark symptoms that make you think UC?
It's the triad: diarrhea, rectal bleeding, and tenesmus. Tenesmus is that constant, painful feeling that you need to have a bowel movement, even when the rectum is empty. It's incredibly distressing for patients.
And the urgency is what keeps patients homebound. They can't go to a grocery store or a movie theater unless they know exactly where the bathroom is.
We classify UC based on how far it has traveled. Proctitis, just the rectum, usually the mildest form, but the tenesmus can be severe. Left-sided colitis, it goes up to the splenic flexure. Extensive colitis or pancolitis, it involves the entire colon.
The further it goes, the more systemic the symptoms. We start seeing weight loss, fatigue, and even fever as the body enters a state of chronic systemic inflammation.
And this is where the target discussion starts. If a patient with pancolitis says they feel better, but they're still having 3 bloody stools a day, that is a failure. We have to be objective.
This is a part of the lesson that I think is vital for all clinicians. UC isn't just a pooping disease. It's a systemic inflammatory condition.
Exactly. About 25% of patients will have symptoms outside of the GI tract. Sometimes these symptoms show up before the diarrhea even starts.
Let's break them down by organ system. The joints, this is the most common. We see peripheral arthritis, usually the large joints like the knees or hips, but we also see axial involvement like ankylosing spondylitis.
And don't forget the eyes, uveitis and episcleritis. If a UC patient complains of eye pain or blurred vision, that is a medical emergency. They need an ophthalmologist immediately.
The liver is another big one. Primary sclerosing cholangitis, or PSL. This is a chronic scarring of the bile ducts. Interestingly, about 70 to 80% of people with PSL also have UC.
This is why our targets have to be broad. If we only treat the gut but ignore the joints or the eyes, we aren't truly treating the patient.
How do we confirm it? We know the symptoms, but how do we prove it's UC?
Endoscopy is the gold standard. We're looking for that continuous inflammation, the loss of vascular markings, and the presence of pseudopolyps, which are just little islands of normal tissue surrounded by ulceration.
And we use the Mayo score to quantify what we see. It's a 0 to 3 scale. 0 is normal. 1 is mild, erythema and decreased vascularity. 2 is moderate, marked erythema, lack of vascular pattern, and erosions. 3 is severe, spontaneous bleeding and large ulcerations.
Histology is key too. We take biopsies to look for crypt abscesses and crypt distortion. This helps us differentiate UC from an acute infection that might look like UC on the surface.
Once we have the diagnosis and the score, we move into the treat-to-target phase.
This is the heart of the modern lesson. We've shifted from a step-up approach to a treat-to-target approach.
In the old days, we'd give a little mesalamine. If that failed, maybe some steroids. We'd wait for the patient to flare before we changed anything. Now we use the STRIDE guidelines.
STRIDE stands for Selecting Therapeutic Targets in Inflammatory Bowel Disease. It sets a hierarchy of goals. Short-term, clinical response. Stop the bleeding, stop the urgency. Intermediate, biomarker healing. We want the CRP, blood, and the fecal calprectin, stool, to normalize. Long-term, endoscopic healing. We want to go back in with a scoop and see a Mayo score of 0.
Why does that Mayo 0 matter so much? Because if the colon looks normal, the risk of a future flare drops by 50%. The risk of surgery drops. The risk of cancer drops.
And the ultimate, most modern target is histological healing. This is when even the pathologist can't find inflammation under the microscope. We're finding that patients who reach histological healing have the best long-term outcomes of all.
It's a lot of work. It means more lab tests and more scopes, but it's the difference between a patient who is getting by and a patient who is thriving.
We have so many tools now. 5 ASAs for mild disease, biologics like anti-TNFs and Entyvio for moderate to severe disease, and now JAK inhibitors. The target is no longer a dream. For most patients, it's an achievable reality.
Well, that's our 40-minute deep dive. UC is complex, it's systemic, and it's biological. But with the right targets, we can change the trajectory of this disease.
Thanks for joining us. Keep aiming for those Mayo zeros.